Hello, my name is Lauren Brown, and I'm excited to talk about the results of our study entitled The Impact of Prehospital Pain Management on Emergency Department Management of Injured Children. I'm happy to be here representing my co-investigators in the authorship team, which includes Matthew Harris, who is the primary author on the manuscript, and the other individuals who served as site PIs and contributed greatly to this work. I'd like to acknowledge that this project is supported in part by the Health Resources and Services Administration, Maternal and Child Health Bureau, Emergency Medical Services for Children Targeted Issues Grant Program, under the grant number listed there. This information or content and conclusions are those of the authors and should not be construed as the official position or policy of, nor should any endorsements be inferred by HRSA, HHS, or the U.S. government. Painful traumatic injuries account for nearly 25% of all pediatric EMS encounters. EMS clinicians, because of their role early on in the care of injured children, are optimally positioned to provide appropriate pain management that may prevent the physical and psychological distress associated with pain, especially helping to prevent those long-term outcomes such as fear of future medical encounters. Prehospital analgesia, however, is only provided in 2 to 20% of children in the EMS setting, depending on the study one references. We do know that children who receive prehospital analgesia do receive their first dose of pain medicine significantly earlier than others who have to wait until the emergency department. However, the true impact of prehospital analgesia on subsequent pain and pain management needs is not known. For children transported by EMS, we evaluated the impact of prehospital pain management interventions on the initial ED pain severity scores, and then the timing and dosing of ED analgesia provided. We did this and tracked EMS interventions that included both pharmacologic, such as opioid medication, and non-pharmacologic interventions, such as splinting an injured extremity, cold application, and those non-pharmacologic interventions. This was a planned secondary analysis of a prospective multi-center cohort of children with known or suspected traumatic injury who were aged 1 month to 17 years at the time of their service, and were transported to one of 11 Pediatric Emergency Care Applied Research Network, or PCARN sites, directly from the scene, between the dates of July 2019 and April 2020. Participating emergency departments were geographically dispersed and are indicated by the green dots on the map included. These were all level 1 pediatric trauma centers and dedicated pediatric pediatric hospitals. We excluded children in traumatic arrest at any time during EMS care with a known hypersensitivity to opioid analgesics or were known to be pregnant at the time of their care. This was a prospective convenient sample of children transported to participate in emergency departments. Enrollment occurred on average 7 days a week, approximately 16 hours a day, to align with the highest volumes of the emergency department. Data were obtained by EMS clinicians' self-report at the time of transfer of care. So the EMS providers were interviewed on site and provided real-time or near real-time prospective observations. And then data were also obtained from the emergency department's electronic medical record. For this secondary analysis, we cohorted patients based on the provision of prehospital analgesia, both pharmacologic and non-pharmacologic. We grouped pain severity scores a priori into mild, with pain severity scores from 0 to 3, moderate, with pain severity scores from 4 to 6, and severe as pain severity scores from 7 to 10. We also converted all administered ED analgesia medications to morphine equivalents to facilitate comparison across patients. Our primary outcome measure was the difference in prehospital and ED pain scores between children who did and did not receive prehospital pain interventions. Our secondary outcome measures included time to first administration of ED opioid analgesia and total morphine equivalents administered in the emergency department. We analyzed our data using means and standard deviations for continuous variables to summarize the data. And then to compare study groups, we used Wilcox and rank sum tests to compare continuous variables and chi-square tests to compare categorical variables. In order to show, to describe the ED analgesia administered over time, we used the complement of the Kaplan-Meier curve. We also used logistic regression to identify models that showed patient and provider characteristics associated with the provision of EMS analgesia. The Cohen-Sart diagram is displayed. We had a total of 597 patients across all sites who were injured, 50 of whom met at least one exclusion criteria, leaving us 547 eligible patients, 46 of whom were missed for inclusion, giving us a total of 501 captured and 474 with complete documentation that were included in our study. Of these, 37% received non-pharmacologic interventions only in the pre-hospital setting, 4% received opioid analgesia only, 14% received both non-pharmacologic and opioid analgesia together, and then 45% received no pain interventions prior to arrival in the emergency department. This is the distribution of pain management interventions provided by the pre-hospital clinicians. As you can see, the majority of children, or 55%, received some sort of pre-hospital pain management intervention, although the majority received non-pharmacologic analgesia only. This is a basic table showing the comparison between, or comparing, those four groups of patients: those who received opioid analgesic only, those who received opioid plus non-pharmacologic analgesia interventions, those who received only non-pharmacologic, and those who did not receive any. They were statistically significant across the board for all of these comparisons, including a change in EMS to ED pain score. Those who received opioid medications had a significantly decreased in their pain score when compared between the EMS and ED initial pain scores. Also a difference in the rate at which ED opioid analgesia was provided with those in the emergency department, with those who had received opioid analgesia needing higher rates of opioid analgesia in the emergency department. Similarly, the spectrum of all analgesia provided in the emergency department, those who received opioid analgesia in the pre-hospital environment had continued and ongoing needs, pain needs in the emergency department. These are similar data that are shown graphically. On the left, you have the distribution of pre-hospital pain severity scores. As you can see, the darker box are those who did not receive opioid analgesia. The lighter box are those who did. And you can see graphically on this box plot that those who did receive opioid analgesia had a significantly higher pain severity score in the pre-hospital setting. However, there was less difference in the emergency department pain scores upon arrival to the emergency department in those who were treated and not treated with opioid analgesia in the pre-hospital setting. So you can see but graphically here that the reduction from pre-hospital to emergency department pain score was greater in the groups that received opioid analgesia than those that did not. And you can see that statistically the pain scores looked much more similar upon ED arrival in those that were treated compared to those that were not. Across the first 2 hours of the emergency department, this is a graphical representation of the cumulative opioid and non-pharmacologic, the cumulative analgesia in the emergency department. The dark dotted line are those who did not receive any pain interventions in the EMS environment. The light dotted line are those that received only non-pharmacologics by EMS. The dark solid line are those who received both opioids and non-pharmacologic interventions in EMS, and the light solid line are those that only received opioids. And you can see that in the first 20 minutes and across all of the first 2 hours of emergency department care, those who received opioid medications in the pre-hospital environment were much more likely to need opioid medications throughout their emergency department stay. So in conclusion, the majority of injured children receive pre-hospital pain management interventions. This is different than what has previously been noted in the literature. Previous literature has really focused on the provision of opioid analgesia, and the minority of patients, less than 20% of those in EMS care, receive opioid interventions. To our knowledge, no previous study has looked at the rate of non-pharmacologic interventions, and when those are included, in the analysis, the majority of EMS patients, of EMS children, do receive some pain interventions. It's just the majority of them are non-pharmacologic in nature. The pre-hospital providers appear to provide opioid analgesia to those with the highest pain severity. And those who received pre-hospital opioid analgesia exhibited a greater reduction in pain severity upon ED arrival, but had continued pain management needs in the ED and required ongoing pain management both early on and throughout their emergency department course. I think these final two bullet points go together, that the really opioid analgesia in the pre-hospital setting, if they are indeed giving it to those with the most severe pain, is probably a marker for ongoing pain needs. They have painful conditions that are going to be persistent and have higher pain intervention needs. And so these last three bullet points probably are related. Thank you for your time. Please feel free to reach out to me, Lauren Brown, or Dr. Matthew Harris at the email addresses there should you have any further questions. I appreciate your time.